Hello, and welcome to today's webinar, CMS Comprehensive Primary Care Initiative, a How-To. Before we get started, I'd like to announce a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few days after the call. You will receive an email from AHIP that will ask you if you would like to receive the archive. Please respond to the email if you would. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the Handouts tab. The antitrust statement prohibits us from discussing competitively sensitive information. Please keep in mind that you may also ask a question at any time during the presentation by typing your question into the chat box located in the lower left-hand corner of your screen and then click Send. You can adjust the size of the slides to fit your screen by clicking on the Scale button located in the upper right-hand side of your screen. We are very fortunate to have with us today Dr. Mark Crockett and Dr. Judy Zerzan. At this time, I'd like to turn the floor over to our speakers.
Thank you very much. This is Mark Crockett. We're going to just briefly introduce ourselves, and I'll start here. So I'm an emergency medicine physician. I practice at Advocate Healthcare in Chicago, Illinois, and of course, Advocate has been doing a lot of accountable care type work with HCSC and Blue Cross Blue Shield since back in 2003. I previously started and ran an emergency department software company, which became part of PISIS and which was eventually a part of United Healthcare's Optum group. And so I've been a provider who's worked for a payer, and now as the CEO of Rise Health, a Best Doctors company, a lot of my work is also done in the provider and the employer space. So today I'm going to be answering questions and talking a little bit about the tool that we use to be as part of this really exciting product, this exciting project. And so and now I'm going to go ahead and turn it over to Dr. Zerzan, who's really the one you came to hear about.
Dr. Zerzan, is your line muted?
Yes. Hello. Good morning, everyone. This is Judy Zerzan. I am the Chief Medical Officer for Colorado Medicaid. I've been here a little over 5 years, and prior to that was in academics and also worked in Senator Rockefeller's office during the Affordable Care Act, which was pretty entertaining, and I learned a lot. And we are very excited today to talk to you about the Colorado Comprehensive Primary Care Initiative, in what we're doing, the process that we've been to, and what we are going to hopefully get out of this RISE tool for our practices and in our market. So to start off with, the Comprehensive Primary Care Initiative is an initiative that has come out of the Center for Medicare and Medicaid Services. In the spring of 2012, CMS started working with private health plans, Medicare and Medicaid, to think about how can they support primary care differently, and how can we really come together as a set of different payers to strengthen that primary care practices to deliver higher quality, better coordinated, and more patient-centered care. The goals of the CPCI program, you can see there's sort of 5 functions here. Care management that's risk stratified, providing access to 24/7 care, delivering more preventative care and planned care for chronic conditions, engaging patients and their caregivers, and then coordinating care across the medical neighborhood. Colorado is one of 7 state markets that was selected by CMS to participate in this initiative, which formally began November 1st of 2012. The payers first signed on, and then CMS's Innovation Center invited practices to apply. And in Colorado, initially 75 primary care practices applied with the goal of looking at this cost reduction, quality of care, improved health outcomes, the triple aim, and also looking at, from the payer side, how we can have enhanced data reporting and analytics, quality measure development, and new payment methodologies. And since most of this webinar is really focused on this data aggregator, the RISE Health tool, I think that that's really one of the unique things about the CPCI. The basis is medical homework in terms of how to support primary care and pay for it differently. But I think one of the new pieces is this data aggregator that we're talking about today. So the vision is this top sort of bar in terms of how do we help practices move across that. And while the CPCI initiative really strives for success through improving the care coordination, the payers saw this lack of integrated data for practices as a persistent obstacle to this ability to really transform their practice. So the payer group, and this was one of the pieces that CMS envisioned in the beginning, although Colorado is one of the first markets to implement this tool. When we do that, I think the end of this month. Mark will talk about that in a minute. But really for practices being able to see data on their panel that goes across payers, particularly when a patient may move from payer to payer, and have common metrics across payers rather than going after one metric for a certain payer but perhaps a different metric in the same category but measured differently for another payer. We really think that this makes the lives of practices easier, and and gives them the ability to have this actionable information to then target their care coordination and target their patient engagement. Some payers across the bottom are using this as another piece in how they transform payment reform from traditional fee-for-service up to managed care, but I would say the goals of each payer in terms of this payment reform are a little bit different. So the team of who is at the table in Colorado, there are actually 9 payers, so the people that you see here, the companies that you see here, but also Medicare is at the table, and Medicare is not yet participating in the data aggregator solution, but both they and us as a group of payers are quite hopeful that they will. Oregon Health Science University is providing the facilitation for this project in our market. They started as a facilitator being paid by CMS, and it worked out quite well for us that the payers have had them continue. And we've been meeting around the table with each other since, I think, early 2013, and I think that that is a very unique part of this initiative as well. We've really established a trust and a good collaboration, even though we each have different organizations, some local, some national. I think we've really developed a strong working relationship with each other with a common goal. So the process to get to this common data aggregator was relatively long, and in fact we recognized that that was an innovative and critical piece of the CPCI project, and so we started talking about it early on, and we learned from a couple of missteps in other markets where people were starting to move toward data aggregation and then for a number of reasons had to stop. So our first decision point was in deciding whether this would be a state-led and state-run procurement process, because as probably most of you know, the state has a number of rules about procurement, or whether this would be a more private-led procurement. And the decision was made by all the payers in aggregation that this was going to be a private-led procurement, although the state participated in those discussions. CMS, representing Medicare, also participated in discussions, but as a private-led process, they had their own decision-making part of this that was not a part of this process. I would say overall it took about a year for this to come into being. We started with an RFI process and then moved into an RFP process. We narrowed it to 2 finalists, which we had come out for demonstration of their products and asking questions, and then settled on RISE. Gosh, I don't have the date in front of me, but I think close to a year ago. And probably the most difficult part of getting through this process is that this is really a new idea and a new tool, and we had to think about what are the goals of each of us from our individual organizations, and also what's the goal as a whole. I think it helped that we had a great deal of trust and collaboration between the payers that had developed since we had been working together. And in terms of what we might do differently, I'm not sure that there's anything that we could have anticipated to do differently. I think one of the ongoing struggles is going to be the ability to have Medicare data in this tool and the ability for CMS to take part in their costs. And as I had mentioned earlier, CMS is committed to that. We are just not quite there yet. So in Colorado, we currently have 7 payers working on this data aggregation. As I mentioned, there's a couple other that are at the table but are not currently contributing data or financial resources to this. There are now 74 practices in this, which represent a little over 93,000 patients. And oh, here's the date. The launch is planned to be next month. So the key objectives of this data aggregator, the first one is to help the CPC practices achieve their milestones. So practices in taking part in this initiative had to agree to 9 different milestones, and they really range the gamut from access in terms of having 24/7 ability to contact a provider, to things like shared decision making and having patient advisory councils for their practice, to identifying issues in quality and then working to improve them. And so one of the things that we wanted to use this data aggregator tool for was to help practices identify and then be able to address areas for improvement. The second one is to successfully create and distribute shared gains within our public and private payer programs. We also thought as payers, having the ability to see some of this data across payers was helpful to all of us. An example is colonoscopy screening. We all want to do it, but if a person moves from plan to plan, that information doesn't always follow them. So this allows us to have a broader sense of whether we're impacting people's health by providing them appropriate preventative and chronic care. The third goal was to collaboratively learn through our shared experience, and then the fourth goal is to build on what is becoming a statewide health information network that helps local communities, that grows and ultimately is sustainable beyond the scope of the CPC initiative. I should also mention that the CPC initiative is a 4-year project, and certainly we're starting to talk about what comes after and how does this fit into other initiatives that we have in our state, including things like the state innovation model, which Colorado was recently awarded, as well as other practice transformation things that we're working on here. So as I mentioned earlier, these are the 7 plans that are submitting their data to the data aggregator, and most are leveraging their connection with our all-payer claims database to provide the feed to RISE that then puts it together and provides this both to practices and the payers. And one of the things that I think is really helpful to talk about is this, these 74 practices run the gamut in terms of practices. We have some small rural practices that really have 1 or 2 primary care providers in them, and then we also have these very large metropolitan practices that are often part of an integrated health system, and then things in between. And I think in particular, some of the small rural practices are quite excited about this data aggregator because they don't have the resources to pull data together and to look at where they might improve or look at their information. Some of the larger practices, for example, might have an actual data or quality person that's helping them work on this, but the smaller ones really don't. And so I think there are places for both the small and the large practices to work on this. So phase 1, where we're currently in, is data aggregation. And currently, as probably most of you know, practices receive multiple reports from each health plan in a variety of electronic and paper formats. And as a general internist myself that still does a baby bit of practice, I can say it's completely not helpful, especially since I have such a small number of patients in my practice that I see, to get these individual reports from different payers to talk about how I'm doing on diabetes care, for example, because the number of people that I have in any one plan is quite small. And the power is really when you can put all that data together. So practices might need to log on to several different websites in order to access patient data. It's really quite burdensome and not very efficient to coordinate patient care. So this data aggregator, in terms of multi-payers and being available from a single source web login that will have both patient and practice level information, I think is really going to advance the ability for practices to change what they're doing and improve patients' health. So all data comes from the payers, so it's all claims data, which is something that we'd like to potentially talk about changing in the future, but for right now we need to walk before we can run, and claims data is certainly the easiest to work on aggregator. So the kinds of data that are going to be available in the tool will be talked about a little bit later by Mark, but there are summary reports. There are a series of quality metrics that CMS initially proposed and all of the payers have agreed on and bought into. Initially, we're going to focus on just a few to make sure that that practices can understand how to use the data, and then we'll be expanding to the suite of measures. People will be able to look at trends in their metrics, at potential quality or care gaps, look eventually at medical costs, and also be able to drill down into things, which Mark will talk about in a minute. So practices will be able to access the data of their attributed patients, and payers will be able to access the aggregated data for their patients, as well as a comparison to a regional HEDIS benchmark to get some idea of where that particular payer stands in comparison to the others that are working on this. One of the other pieces of CPC initiative that I didn't mention earlier is that CMS has been supporting some sort of at the elbow practice transformation support. So depending on which side of the mountains you live in Colorado, there are 2 different teams that go out into practices that are helping practices change how they do business, how they work as teams, how they work at care coordination, and we're also going to help use those people to help practices be able to use this tool and how to look at it. So, I guess I talked some about the comprehensive reports, but I'm going to pass this over to Mark now to talk a little bit more about what their tool can do and how it works.
Fantastic. Thank you very much. So, you heard a little bit about what's going on in the application. Let me just give you a little bit of background on it, and that is that, this is a tool that was developed by our organization to support large payer organizations and provider organizations in care coordination activities inside the practices. And it was developed, our organization, Rise Health, has been doing this type of work for some time. And we are a part of a large organization called Best Doctors, which is the world leader in second opinion services and medical excellence for the top few percentage in patients in terms of healthcare costs and quality. So we do this for a large number of organizations for payer, provider, and also for employers. So what I'm going to talk about today here is, the subset of features that are going to be used in this particular piece of this project. So in terms of phase one, the application itself is Stratus is our analytics platform, and so we're aggregating data from a large number of payer sources, but it can also bring in future phases provider data. The kind of work that we're going to be able to give people in the first phase of this is summary reports in terms of practices. How many attributed lives, how many risk patients do you have, what are the types of patients that you have, and a lot of things around diagnostics. Key performance indicators. Our key performance indicators and our risk are tightly linked, and so what we found is that providers find it very interesting as they start to see things like this is how many admissions and readmissions you have, and then you start to look at things like, well, my quality numbers are good, but access to care is more of a problem in my practice. So, what I see is that, as we give these kinds of summary reports and sort of KPIs, the ability to drill very quickly down to the actual individual patient level across a variety of different payers means that you have a visibility into a good piece of your practice, and you have good visibility into things that are either operational or at least proxies for operational. So with primary care physicians, when you start talking to them about these are the number of patients and the trends around patients that are seeing the emergency department multiple times in between primary care physician visits, and then you can get them down to the individual patients that are doing that type of activity, you can really start to drive action. And so there are some standard things like HEDIS quality and care gaps, some things about continuity of care that are interesting, but also a comprehensive look at medical cost. And so when we start to look at patients, particularly in the primary care physician's offices, and we say, here is your patient that is taking 10 medications at this tremendous expense level. When an awful lot of those medications may have been prescribed by other physicians, perhaps out of network or specialists that are not necessarily with the provider every day in coordination. And so giving visibility across a large number of patients and a large area of the patient's care in terms of cost, quality, registries, and being able to drill down to the individual patient level, that's been the thing that I think was what's really special about the tool. And we link this to a patient engagement platform that's essentially not a part of this project. So let's see if I can move the slides. So this registry view is, I think, one of the really important pieces of it is the ability to take any one of our reports and then get down and provide that list to the patient themselves, to the provider, and get down to the individual patients. Providers know what to do with this information. When we start to say to them, here's your diabetics who are on more than 10 medications, who are depressed, who live a certain distance from their provider, these are the kinds of reports and lists that, as they're generated dynamically and they can look at this frequently, they can really drive action off of that. Medical cost drill downs, again, giving them sort of baseline reports, but then linking this through to their strategies in terms of how they refer patients. This has been something that has also been really well received. And then provider analysis. This is one of those things where, as you look at a group of providers, and I practice emergency medicine. If you ask, the doctors in my group, who is better at e-prescribing, who's doing these various things in terms of cost and quality, every single one of us would tell you that we're going to be in the top half of that list. But what we find is that, providers, when they look at these lists, even if they show up in the lower portion of a given graph in terms of provider analysis on any one of these metrics, when you can then take them down to that registry level and say these are the patients that are contributing to this, you really start to see with that visibility an understanding that sometimes that kind of behavior is patient-driven, sometimes that is network or referral-driven, and sometimes it's just patients that are particularly difficult and complicated, but at least they know how to focus. And so being able to give these kinds of lists that they can look at any time across a wide variety of patients, we've seen people use this very effectively to manage their practices differently. So these are some of the views that people are going to be getting in that first cut of the of this tool. And some of the tabs that you can't see here, things like chronic patients visiting the emergency department multiple times, patients seeing emergency department multiple times between primary care visits. These are proxies for access and operational issues inside the practices that we can really, that we can really provide some help with. And so being able to have multiple payers contribute, and then our hope is at some point here to add in provider data for some of the practices, you can really get to a really great visibility around these things. The big questions that we see, I think this was a. Do you want to address this, Dr. Sarah? I think this was when I was supposed to turn it back over to you.
Yes. So these are common questions that we've got that I thought we'd sort of go over now. So the aggregated data by this tool will not be used in contracting, which I think is certainly one of the fears of practices, is how are payers going to be using this data and what does that mean? And for us as a group of payers, we really want this tool to support the practice transformation work. And doing that by providing these previously unavailable information on claims cost utilization across the medical neighborhood and across payers in a user-friendly format. So we really want this tool to bolster the work that practices are already doing. And I think work on the medical home has been promising, but not a home run in every setting that has been done. And so I think it's going to be really interesting to see what this tool is able to add on to that medical home work. So this tool for practices offers, I think, a very innovative, and I have to say, as probably many other payers have, we have our own tool for Colorado Medicaid, and this one is much more user-friendly in terms of a mechanism for practices to access and interact with their patient population data. I'll also say, and as an internist, using data is not necessarily everyone's strength, and so I think that this tool is going to help. Part of the reason why payers have invested in this resource is that this is going to really help practices be able to use data in a way that they haven't to support that practice level transformation in terms of both care delivery and the business of their practice. So more information about how to use this tool and how we think that this will be helpful for that practice transformation is going to be provided through the regional learning faculty. That's the group that I mentioned earlier that is supported by CMS, and also through Rise Health about how to use this information in your practice and how to maximize the value of this tool. And then practices are going to be able to use data in a manner that they want through this customizable dashboard so that they can focus on perhaps what pieces they want to look at or what's most important to their practice. And certainly the milestones in CPC initiative encourage practices to target places to work on, and so I think that this tool will help them be able to do that. Rise Health is hosting a series of webinars to help train practices on the use of the tool, and they're also going to attend an in-person spring learning session to provide some in-person training, support, troubleshooting that I think will help practices figure out how to use that. RISE is also providing each practice a service agreement that allows practices to access the tool, and for practices there's no cost for this tool. The payers are bearing the cost of this. We have a set number of licenses for each practice, and we're going to work out sort of how that looks and what that looks, but for the practice, there's no cost, which I think is pretty handy. So I'm going to turn it back over to Mark now to talk about phase 2, which is something that I would say as a group of payers is a glimmer in our eye, but does seem like an extension of this work and moving it to the next level.
That sounds great. And there have been a couple of questions that have come in that I think kind of that we could address them as a part of this discussion. So, there's a lot of some questions have come in around the data itself in terms of how near term is the data. And so the tool is designed to aggregate data with a variety of different latencies. And it's designed to do so without having to torture the people who are providing the data. So if a given payer provides data in a particular format versus another one, and if a given EMR provides data in a format versus another one, and all the EMRs provide data differently. Some of them can't provide the data at all. You have to go in and get it. So these types of things are addressed in the tool, and so you'll find that the more data feeds we get, which are more real time and are closer to the source, the better. And so the data for this project, the payers have been fantastic about getting us claims, and it's claims data, but getting it much more close to the event than we are used to seeing in some of our other projects, and getting it more frequently. And so I think that's all I'll say. But congratulations to the technical teams of the payers for having created and gotten us feeds in a very short period of time. And we're also using the All Payer Claims database. The All Payer Claims database is a Colorado function, which is an absolutely fantastic resource for getting more data into a centralized location than we're used to in other projects as well. So there's some really nice things. And as you look into phase 2, adding additional data sources to the integration process, being able to get events as they occur. One of the frustrations as a provider is when you have a patient who is, you believe that you are taking care of the patient for the preponderance of their care, and then they go outside of network or they go to someone else, they get a second opinion, and they're off to their races, and they do a whole bunch of work. Often wind up getting the same answers that you were giving them in the first place. And so getting to closer data so that you can work with the patients to make sure that you're engaging people the way they want to be engaged, and using data that's really accurate and relevant, can be really important in terms of making sure patients are getting evidence-based care around things like back pain and musculoskeletal in particular, and other types of things. So we're adding additional data sources and more real-time data sources, adding additional support for more sophisticated clinical analytics and population health management. We have we have a tool that is an engagement tool that's integrated right into this. We are also willing to integrate with other tools, and so as we see people moving in the marketplace, we expect this data to be really useful to the practices in a variety of different contexts. When we talk about more sophisticated clinical analytics, we have really found that some of the patient-reported data has been very useful in terms of real management. Patients can tell you a lot, and as you engage with them, in our projects, what we attempt to do is get to a point where you can use the analytics tool to find the patient for intervention. Then you can do the intervention and then measure the effectiveness of the intervention in one database. And so we get closer and closer to that in phase 2 of in the medium term here with Colorado. We really just couldn't be more excited about it. some of those data sources. Obviously EHR data, prescription data, pharmacy claims, care coordination interactions, practice management data. These are things that our company is very familiar with, all of those, and how to get all of those into one platform. And so really, as a part of Colorado, we're doing a lot with the payer data to start with, but the next phases of the project involve adding these things in, and being able to work with hospital discharge ADT feeds and other types of information around how and when patients are admitted becomes a key part of making sure that you can seamlessly coordinate that post-care environment that's so critical to preventing readmissions and driving down costs. I think if one of the things that we found is that as we work with the practices, practices do have, to a certain extent, an idea of, if you're a provider, you see 16 patients in your morning session. One of the things that we found is those 16 patients in the morning session are well taken care of during their office visit. But if you look at the preponderance of communication with the patients, a lot of that is inbound phone calls, things like medication refills, billing questions, etc. The customer service model has not been one that, it's not been some place that you've seen a lot of attention paid on the provider side. And what we found is that in a value-based care scenario, the relationship between the payer, provider, and patient, getting that into a place where everybody is aware of it, you want to embrace that and get that relationship into a great place. What we found is that the inbound phone calls in a customer relationship management type of approach can be fantastic if you embed the clinical scenario into that. And we've done some great work in Massachusetts with the Blue Cross Blue Shield alternative cost and quality contract in terms of showing that all you have to do is field the inbound phone call, and that inbound phone call, your contact rate there is 100%. And those patients have a totally different psychology when you answer the phone in a way that shows that you know what you're talking about, you understand what their issues are, and you can mobilize that relationship and create great care right inside the customer service model. That's just an example of one of the tools we use for engagement. The mechanics of the tool, obviously lots of different payers into the integration engine, and then Stratus, which is our analytics piece, creates all of the insights and the risk models off of that. And the nice thing about the engagement tools is that they're built on the same database. So it's, bring the data together, analyze and understand your patients, understand who you need to go out and grab a cohort of patients, and then go work on them. One of the things that's come out that's kind of interesting about our previous projects is that 3% of patients drive up to 30 or 35% of all medical costs, and so by addressing things in the really the acute and post-acute care patients in a different way, you can drive clinical programs that can be really remarkably effective in lowering cost of care. And I think that my browser is no longer responding. So I think, Dr. Zerzan, if you wanted to take over from here, that would probably be smart.
Okay. Well, the handy thing is this is our last slide. So we've been getting a number of questions over the chat box. And Carrie, I think you're going to sort of take it from the top and help us through them.
Great. Thank you so much. At this time, we are going to address the questions that came in during the presentation. If you'd like to ask a question, you can do so by entering it in the chat pod and hitting the send button. So the first question reads, what are the barriers preventing Medicare from sharing data? This is not the first time I'm hearing about Medicare's commitment, but lack of follow-through.
So to CMS's credit, they certainly want to participate. I think one of the tough pieces, and actually we've been experiencing this somewhat on the state side, is that federal procurement rules are complicated and long. And one of the things that I didn't mention at the beginning, of the guests I sort of glossed over is that one of the things that happened in another market about why they were not able to move forward as they wanted to with the data aggregator is that they were going to have a CMS-led procurement process, but that proved to be quite lengthy and involved. And so it was one of the reasons that we decided to have the private insurers lead the procurement process, which again, from my standpoint, I would say was just as intensive and as rigorous as a process as our state process would have been, but slightly different. I mean, it was certainly a competitive process. So CMS is hoping to come in after this is set up and running and have moved a lot of things through both CMS and the Congressional Budget Office that has to approve this funding. But things on the federal level are a bit more complicated and quite a bit slower. So we're hopeful and I think mostly confident that they'll come along, but right now waiting.
Great, thank you. The next question reads, Grand Junction, Colorado is cited as a model community for Medicare. Can you look at stats community by community?
So this is Judy, and I'll start, but then maybe Mark can jump in on the end. So practices are only going to be able to see the data for their own practice, and then us as payers is going to be able to see the overall data and our own individual data for the practices that are in there, but I'm not sure how it looks at things regionally or by communities, the RISE tool.
Yeah, so the data is organized around patients and groups of patients, and so it's not difficult at all to cut that a number of different ways, and you can look at it by community. One of the things that we do see is that is region by region looks by payers at that to see how people are performing in a region. I think that as we have this warehouse growing with lots of information in it, there will be a lot of different people looking at ways in which that will be which that will be used. I think one of the really exciting things about working with Colorado is I think they have a better idea of governance than I think a more sophisticated view of governments than I've seen. And so it really is wonderful to think about the fact that I think you'll see additional people queuing up and getting a look at this data, but it will be something that the payers feel comfortable with, that the providers feel comfortable with, and that the public feels comfortable with.
Great, thank you. And then we had two questions that I think kind of go together. The person is asking, is the data available to ER docs? And then they also asked, do patients have access to the data?
So that's a really good question, and the answer is no to both of those. So right now, practices and payers are the ones that have access to the data. There may be some iteration in the future, particularly how this interacts with our state HIE system that may develop in the future, but and what access to patients this might have, but right now this is where we're starting, and for the foreseeable future, sort of where the data will be available.
Great, thank you. And how quickly is the information processed? How recent is the data?
I think I can take that one. So basically, the system is sophisticated enough to handle millions and millions of claims, and we handle millions of claims daily. So really, I think the question is, how long did it take to get us that claim? And so that's one of those things where each payer is a little bit different in terms of their own internal processes. But once again, we've seen the payers in this particular situation, really being efficient about getting us data. And so, I would say it probably runs the gamut from a couple of weeks to a couple of months. That said, and so there's certain work that can be done, in fact, best done with that type of information. On the other hand, the system is built to take data and act on it very quickly. So when an ADT comes in from the hospital saying the patient was just discharged, having that be immediately available in the care coordination platform for somebody immediately to be dispatched to be able to care for that patient. Those are the kinds of things that it's built to do. So in the context of this particular project, call it weeks to months, and then as we go into phase 2 or future phases of it and get data sets that are more real time, that just continues to improve.
Great, thank you. The next question reads, are the coverage plans typically open access or gatekeeper?
This is Judy, and I'm not totally sure because each payer manages that on our own. It's not been a topic of conversation for us as a group. I will say that for the private plan payers, not all of their lines of business are taking part in this necessarily, with probably the biggest gap being employer-sponsored plans. And so in some cases, only pieces of a plan's lines of business are contained within the CPC initiative.
Thank you. And when is this coming to Miami, Florida?
So this is one of the demonstration projects from the CMS Innovation Center, and they have currently, I think maybe 4 weeks ago, have just released their report on the first year findings in terms of data, and they are finding for the Medicare side of things that there are some cost savings that almost cover the additional amounts that they're paying out to primary care practices. So I think that will continue to evolve. As I mentioned earlier, it's a 4-year demonstration, and right now we're starting to have conversations with CMS and among each other as payers about what happens after those 4 years. For Colorado, the state innovation model might be a way to continue some of this work, but I think this is one of the demonstrations, to get back to your question, that CMS is trying to sort of see what works, and then if things work, they'll probably expand it to other markets.
Great, thank you. Next question reads, are any FQHC organizations and or Denver Health involved in this project?
So they are not, and that was an explicit exclusion by CMS in terms of practices that were eligible to apply for this. There have been other demonstrations, including some ongoing, that FQs were able to apply for, and so they really focus this around different kinds of practices.
Great, thank you. And what is your recommendation for people in states that do not have an APCD? Is an APCD an important aspect to maximize this practice management tool?
I can take that one. Helpful, certainly, but primarily because it gets people thinking about the fact that you're wanting the plans to contribute to a central location. In terms of who aggregates that, not necessarily. It is. The important thing is to be working with people who know data well and know different varieties of data and who are not going to place a lot of restrictions on how the data comes to them, but are going to get the data and then by hook or by crook, leverage it into their databases. And so an openness to a variety of different formats, different files, different types, different latencies of data, I think that's a key aspect of whoever aggregates the data. And I think that if you don't have an all-payer claims, I think you're ahead if you have an all-payer claims database, because at least the payers have been thinking about on what's the governance model, what are the things that we're going to want in terms of security, et cetera, around those claims so that we make sure that they're being used for the right purposes.
Great, thank you. And I will address the next question. It asks if the slides will be made available. And the response to that is that you will receive an email from AHIP that will ask if you'd like to receive the archive. Please respond to that email if you would like an archive of today's presentation. And our next question for our presenters, another word to use in place of markets is communities. How do you see this as a tool to help address health disparities via practice management and transformation?
Judy, I was going to let you take that one.
Okay. I was like, I don't know, do you want to talk about, so the demographic data is in there, so I think that practices could use this to look at health disparities. And I think, again, sort of the power of having it be across payers, so you really do have that overall look at what your practice looks like and where there are disparities, I think is going to be very useful. How that data sort of trickles out to other community organizations, I think is part of that practice transformation and part of how a practice might help bring in outside entities or local public health agencies or community health workers to help them do this work that I think will be interesting. Certainly one of the topics that we had discussion amongst ourselves as payers is that the benchmark that RISE is going to use is a commercial payer benchmark. And as any of you that do work in the Medicaid space, our Medicaid metrics are quite a bit lower than the commercial ones for sort of a variety of reasons, but a piece of that is health disparities. And so I think it'll be interesting to sort of see how this might impact some of those rates in the Medicaid population and whether there are able to be some differences gained in some of those metrics for us.
And from my perspective, we spend a lot of time thinking about value-based care. And so, this tool was designed for that. And so as we look at some of the barriers to a given patient on an individual patient level, they do boil down to demographics and challenges in terms of mobility, et cetera. And so, we see it in a practical way as those are barriers that we need to help solve. And so where we look at the communities, we're looking at, the individual challenges down to the patient level.
Great, thank you. Our next question reads, is the RISE tool something that can be connected to any EHR to cull EHR data? And if so, can additional Colorado practices not already part of the project participate?
So I can take that one too. So yes, it can be connected to any EHR. And so if you look at places that we work with, Integrated Health Partners in Michigan, for example, there's 5 different payers coming into that, including one large employer and 5 different electronic medical records coming into that system in order to help to do essentially similar work. And so Colorado is certainly a place that we do bring our software in, and we are, we license our software to Colorado providers outside of the CPC project. But I'm pretty sure, Judy, that at this point, it's not open to further people now. You could answer that better than I can.
Yes. This is right now only for the 74 practices that are a part of the CPC initiative. And if this works, then I think both Medicare and the payer group are interested in seeing how we can use this in other ways. But since this is a pretty new tool, we are setting it up just in these practices, and then depending on our outcomes, we'll think about how it spreads to other places.
Great, thank you. The next question reads, could you say more about care management data? Are primary care providers alerted when a client is admitted or discharged from a hospital or a nursing home?
So right now, what is in the RISE tool is strictly claims data. So there aren't ADT feeds or other pieces of that. And as Mark mentioned in his part of the presentation, that might be a future place for us to go. It also doesn't have care management tools or care plans within it, which certainly in Colorado Medicaid, we have the problem of a goat rodeo of care coordinators. And I'm certain other plans are the same, where a patient might have multiple care coordinators, one from the hospital, one for their behavioral health, one for their primary care, and they don't necessarily talk to each other, and that's certainly something that we've talked about as a group of payers, but something that seemed like a big problem to chew off initially. And so I think some of those things will be interesting future conversations, but not something that we're contemplating at this time.
Great, thank you. And Can you tell some stories about instances in which this has had a significant effect on a patient's care?
I can probably take that. This is this tool goes live in like April as our time frame here for this in Colorado. So but I can give you stories, from other places where we've implemented this, and they, obviously being a little bit general about it for privacy concerns. But if you, we have lots and lots of stories where our clients will tell us, we have a patient was discharged from the hospital with a new medication, and called the practice for something completely different. Patient calls in the practice, phone goes to the coordinator who knows the patient, right? And we're using technology to make sure that that patient gets directly to the person who's always used to working with them, and all the information comes up that has been aggregated into the system so that it's understood. So as the phone call comes in, it comes to Terry. Terry's worked with this patient before, and up comes the patient is on these medications. And they're looking at it and they're saying, any medication reactions or anything that well, no, I don't have any medication reactions, but I am getting spots. Well, that counts as a medication reaction. It turns out that here's a patient developing a pretty significant sulfa allergy while on the phone with their care coordinator. So we have lots and lots of those stories that are sort of day-to-day ones. We've got some spectacular stories. You look at what the work we do with Best Doctors on the employer side is to take the same data. So a patient who has who's an executive at a company who is a younger woman diagnosed with a tumor, and turns out to be cancer. And when you look at the data, you think, well, that's of a cancer that usually only happens to a very small number of people, and usually not to younger females. And so, invoking our second opinion service to go ahead and get, the very best expert in the country on, cancer of that particular type for that patient, and finding out that this is not the cancer they thought they were dealing with, and it turned out to be something that was, treatable without any kind of surgical means. We have lots and lots of those stories. So, happy to discuss them, personally with anybody who wanted to reach out and connect with me. But I think that we have some of the highest satisfaction among patients. The patients love to report that they have a great relationship with the practice. And then if we have lots of stories to talk about how that practice uses that customer service, and to have a relationship with the patient that is very meaningful. And so if you look at a 14% decrease in readmissions in one of our Massachusetts projects, you can tie it directly to the fact that the number one relationship in terms of how you get care is with your family, and the number two is with your doctor. And so being able to tie that relationship up tight and then use it for something that we're all aligned around, which is to decrease costs and decrease quality, is something that we've seen that I've got lots of stories to talk about how that works on an individual basis.
And this is Judy to add on to that somewhat. As I mentioned earlier for Colorado Medicaid, and I'm certain other payers have this as well, we have our own portal that providers can look into and look at claims data, and I certainly have a number of stories about the ability to look at that data and identify needs for care coordination or make a pretty significant impact in a person's life. But I think one of the really unique things that this tool allows us to do is, say in an economic downturn, we might have a new client come onto our rolls on Medicaid that has had private insurance before, and to us, it's a blank box. So if you looked into our tool, there would be no history. You wouldn't be able to see anything. Whereas being able to see all payers and see a person move from potentially payer to payer to payer, you're able to identify trends or potentially unmet needs that might not have been able to be seen before because just the information hasn't been there. Certainly, we have so many stories about people with chronic diseases or undiagnosed behavioral health conditions that have had pretty significant gaps in care that our own tool has picked up, and I think the power of this is that just amplifies it. I also think that for some practices, Medicaid isn't a huge line of business for them, and I fully recognize that. And so it can be hard to get practice transformation with just a view from one payer. And so I think having all the payers work together on this really gives a momentum and a bit of a shift to have much more power to really create that transformation within a practice and make it stick, because you have all the data there and all of the payers are working together to help support primary care in some of that transformation.
I agree, and the practice impacts here can be significant. When you can say to a doctor, in your practice, patients call you and then they don't come in because your staff is telling them that they can't be seen for 2 weeks. On a routine basis. And so your emergency department, you don't think they're going to the emergency department because you're not attached to that data set and you don't see that. That has been tremendously helpful to practices to be able to design for access and design for value-based care in a completely different way. And so I love those systemic changes when you can really see impacts that hit all the patients.
Great. Thank you so much for that great presentation and for sharing your thoughts today. Thank you to the audience for participating in today's conference. That concludes this webinar. Thank you again, and enjoy the rest of your day.